Yeah. Okay, so today we are doing this presentation, so it will only take me like 15-20 minutes. And guys, if you have got a question, please do ask me. Okay. The reason why I'm doing this old age psychosis is we have got a lot of patients with psychosis that comes. Okay, and it's especially important for you junior doctors to know, the difference between the psychosis that we see in general adult and old age. The variation is a little bit different. Okay, so I go to the next slide. There are some statistics. I think this is only relevant for people who are giving MR psych, but for other people it's not much. So it's quite interesting that you see 20% of people with schizophrenia having their first episode at 40. So this is called late onset psychosis. Can you take a guess? Normally when a psychosis starts, what age does it normally start in general?
20,
18, 19. Okay, and it's quite interesting that in female and male, if you look at the population, is it male or female where psychosis schizophrenic happened earlier?
It's female.
Female. Okay, so if you look at the stats, the female happened 17 to 18, and male, normally around like 20, 21. Okay, you can also see that there's also a prevalence of having schizophrenia over the age of 65. So when I worked in old age for the first time, I had a kind of like misconception that the schizophrenia only happened during the general adult, and if it happened in the old age, it's unusual. But keep in mind that it's not unusual. Okay, schizophrenia can also happen in the old age. The thing is, most of these patients where the prevalence of schizophrenia that happens in old age, they might have a problem, but they might not have come in contact with the mental health services. That's the reason why we don't notice this population. Yeah. Okay. Go to the next one. So especially in the everyday, if you look at the psychosis, there are a number of factors that taken are there for them to have psychosis. One is age related. Okay. So any patient that is admitted to us, the reason why we tend to do the scan is, why do you think so? Organic. Okay. And especially what I've noticed working in the old age is, especially if you do the MRI scan, you see that temporal side is the one that is a bit atrophied. Okay, and if you see some changes with the frontal, you also see the change with personality and the planning and execution. So it's very, very important. Anyone admitted over the age of 65, make sure you rule out the organic cause. So you guys have noticed that when the patient is admitted, blood's physical things needs to be ruled out, and we tend to do the scan of the head. Okay, keep in mind when we grade older, there are also some neurochemical changes that happens. Yeah, so we also need to keep in mind when we say of sensory defect, what are the things that comes to your mind? Visual. Any other thing? Hearing. Any other thing? How many sense organs do we have? 5. Okay. So as we get older, those sense organs might go down, and that can also give you an impression that whether it's a psychosis. I've seen a lot of patients with having tinnitus, ringing in the ear. They feel like they're hearing voices. Okay. When they are sent to the ENT, and when that problem is corrected, those those kind of symptoms resolve on their own. So don't assume that if they hear the tinnitus, they might confuse for hearing voices. Okay. So make sure before you jump to the psychosis, rule out those kind of things. Okay. Cognitive decline. Cognitive decline is also very common. Sometimes with the cognitive decline, we jump to psychosis. So that's the reason why when patient is admitted to our, we tend to do the full OT assessment. We try to find the basic baseline that we are aiming for. Okay. So the cognitive decline is one of the things. And with dementia, you can also see dementia. There's behavior and psychological disturbance, which we see in the beta later. Okay. And especially can you guys tell which are the types of dementia where we see psychosis? Lewy body. Any other? Can we see in vascular dementia? Maybe we can see. Okay. So there could be a possibility. So please keep this in mind. Okay. Social isolation is also one of the things. Yeah? As we go older, the family, they move far away, and sometimes they don't have anything to occupy themselves, and this is also one of the risk factors. Polypharmacy. Is it common to see a polypharmacy in old age? Okay, so that's the reason why a patient is admitted to us. We do a very detailed history of polypharmacy. Okay, And especially in the old age, have you heard about anticholinergic burdens? Okay, so the anticholinergic burden can also give you the impression of having, the psychosis and the side effects of all the medication. Okay, I've seen a few patients in community where there are a lot of medication, and there were no method for them to monitor, and one of the patients was putting all of the tablets in the bottle. Okay, and she was putting the hand, and whatever she could get, she was taking it. And if she missed the important medication, then we notice that if the antipsychotic medications are missing, then we notice a relapse. Okay, so polypharmacy is also one of the things that you need to take. Okay, on to the next one. Okay, now the consequences of having psychosis, we can see a lot of things. Disruptive, aggressive behavior, neglect, abuse, carers distress. Carers are not able to understand why they are acting in this way. Okay, we also see. Do we see this one? What do you mean by this?
In hospital.
Hospital, care homes.
Care homes and this and that. Yeah. And especially people with having a lot of physical health, they will say, this is normal for them, but they ignore the psychosis. Okay, so keep in mind, if people come from the care home, okay, don't assume that it's just because of the physical health thing. We also need to keep psychosis as one of the differential diagnoses. Sometimes just being in that place for like care home and this doesn't mean that they get immunity with psychosis. Does that make sense? So this means to financial burden. Where do we see more of financial burden and coming with psychosis? Is it male or female?
I think it's female. Females?
Male.
Oh, male.
Male population. Especially at the time of retirement, or if there's a big change, or there's like a divorce or single, you see especially in the male. Okay? Because the male population, sometimes they have the identity that being in the work is my identity. For example, if someone has worked as a police officer for like 20 years, they think that they are a police officer. Okay, so once they retire, they cannot be a police officer, and there's a kind of like identity crisis. Okay, and we have seen a couple of patients with this one. So for confidential issue, I'm not going to tell them. Okay, so are you clear with the consequences? Keep in mind, these two are the main reasons where we get section 2 and section 3, and a patient get admitted to the hospital. Yeah, on to the next one. When we rule out the psychosis, 3 Ds are very important. Which are the 3 Ds?
Depression, delirium, dementia.
Dementia. Okay. So if the 3 Ds come, which is the first thing you need to address? Delirium, because it's reversible. If you treat the infection, it can get better. Then it comes depression. Depression is also reversible. Dementia, then only we think about dementia. Okay. So keep this in the main diagnosis. You can also see that psychosis can be secondary because of the 3 Ds. Okay, delirium, dementia, and depression. So keep this in mind. The psychosis can be byproduct of those 3. Yeah? We also see this functional kind of thing. Okay, move to the next one. So this is just for the people who are giving MSpsych. In the past they were called with different terms. So these people forget about it. Next. Okay. So we can also see that chronic schizophrenia. What do you mean by chronic schizophrenia?
So if the person relapses for a long period of time, like the period of relapse is quite long.
So that is one. The main, why do we think it's graduate? Because people might have 40 or 50 year history of schizophrenia. Okay, and keep in mind with every episode of schizophrenic or psychosis, the baseline drops. Okay, so you have noticed that a lot of the patients that we have having 40 or 50 year history of schizoaffective or paranoid schizophrenia, we can see that they are not able to manage, the day-to-day activities, and they need a lot of input. Okay, so you find this is chronic schizophrenia. Late onset schizophrenia onset is at 40. Okay, so when the patient comes, make sure you take a detailed history and know when did the psychosis happen in the first time. So we need to spend a lot of time, exploring about the timeline. So the timeline is very important. Okay, and very late onset is happened in the 60s. Okay, so keep in mind that age is not an immunity for not having schizophrenia or psychosis. Yeah, on to the next one. So overall, you can see that in the elderly population also, chronic schizophrenia is 85% because the population is growing. older. Okay, so we find 85% of the with chronic schizophrenia having schizophrenia for, let us say, 40 or 50-year history. Okay, late onset you will find 23.5%. Okay, and very late onset you will find less in the population if you go down. Okay, now there are some patterns that we can notice if you take a history. Genetic risk is there, but genetic risk doesn't mean that it will definitely happen. Okay, so it says that if one parent have got schizophrenia, what's the risk of the children having schizophrenia in the lifetime? Any guesses?
I think 5%. I'm not sure, but it's low.
5 to 10%. Okay, but if you flip the thing around, there's also 90% chance of not having it. Does that make sense? Okay, presence of positive symptoms. When you say positive symptoms, what are the positive symptoms? Hallucination, hearing voices, being paranoid. Okay, and early you will also see there's a bit of like psychosocial kind of difficulties with them. Yeah, subtle brain abnormalities. Okay, and, you can see that especially with learning disability as well as people having autism or this, they are more prone to have psychosis. Yeah. Difference is they will have fewer of negative symptoms. Yeah, better psychosocial performance, response to antipsychotic. This is if it happens in late, the prognosis is good. But if it happens in early, the prognosis is not very good. Yeah. Okay, go to the next one. Okay, so very late onset. Okay, higher in female gender, sensory impairment, social isolation, tardive dyskinesia. What do you mean by tardive dyskinesia? Have you seen any tardive dyskinesia?
Tardive is late, so delayed, so it's abnormal movements from prolonged use of antipsychotics.
Yeah. Have you seen any cows like? Children. Okay. And formal thought disorders, blunting, and family history. Okay. So if you can see this comparison, okay. So you must have noticed on the ward, the way we treat the early is different, late is different, and very late is different. Okay. Because the way they present is quite different. Okay. Is there anything that you have noticed over here? If you notice, the late onset, negative symptom and thought disorder is more present. Does that make sense? And if you, this is late between 40 to 60, but if you see very late, you can see there is a brain organic is present. Okay, you should never ignore this kind of thing. But if it is very late onset, you will also notice that most of them they will have a good childhood. It only happens later. Okay. And have you noticed anything?
Can I ask?
Yeah.
If the organic brain pathology is only present in very late, can you even say it's the same disease?
This data is collected from a cohort of sample. Does that make sense? But the patient that we have, it's not necessary that it will fit this cohort.
I see.
Does that make sense?
It makes sense.
Yeah. So this is just like for our guidance, but we need to take in each individual case as it comes. Yeah. Okay. It's the same thing. Yeah. Okay. Biology of schizophrenia, female gender. Why do you think this happens in female?
Is it because of the hormonal changes?
Hormonal, menopause. Okay. Estrogen. Yeah. Brain volume loss in parietal lobe.
So
This is just some studies, but there's a biasness in the study. Yeah. Next one. So there are different kind of hypotheses: genetic susceptibility, neuronal loss. As they grow older, some of the neurons are also lost in the brain. Okay, forget about it. Positive symptoms. Do you think with psychosis you also get depression, especially in the older population?
Yeah, that could
Yeah.
happen.
Okay, you will see 2 out of 5 clinically depressed. A lot of physical health problem, poor support, smoking twice in general population, alcohol consumption is lowering. Can you make this assumption?
I think it depends on the individual.
Individual. So ignore this one. Okay. But if you are taking history, make sure you also cover this one, alcohol and smoking. Yeah. Next one. One of the things that is ignored in general adult and old age is the physical health problems also contributes for mental health problem. Okay, one of the things I've noticed in old age, we are very good in covering the physical health problem, but in general adult, they don't have time, revolving door. Okay, so make sure before you jump to the mental health, fully explore the physical health side. Okay, is this clear?
Mm-hmm.
Psychiatrists missed half of the physical problem. Why do you think so?
We just assume that the physical side have done everything.
No, none of my problem. Junior doctor, please take care. Okay, so keep in mind that we also need to take into hypertension, diabetes, respiratory problem, and hepatic ulcer. Sometimes they can also contribute for the psychosis. So that's the reason why in our ward we don't tend to start the medication straight away. We give at least 1 or 2 weeks for the physical health to settle down before we jump to the mental health side. Okay, next. Okay, so these are some of the cognitive defect. We can see with psychosis it also impacts the language, executive function, memory, and it also impacts the other. Why do you think these areas are impacted if someone has got psychosis? Especially it happens with chronic schizophrenia. Why do you think so? Any ideas?
The executive function is mainly frontal lobe.
Frontal lobe, and keep in mind that if someone have too many kind of like relapse, they don't have opportunity to develop the coping skills. Does that make sense? Okay. If someone has got schizophrenia from 18 or 19, and if they have multiple admissions, most likely they might not be able to held up with stable relationship, stable job. Okay, so that can also impact this function if you look at the long run. And keep in mind, if someone has got schizophrenic, there are also risk of having dementia earlier than the normal population. So when we choose the antipsychotic, especially with the elderly population, we also need to be aware of the cardiovascular risk. Okay, why do you think so? Any guesses?
Just doing psychotic
Side effects. Yeah.
Risk of stroke.
Yeah, and it's not just the medication that we need to focus. Okay, we also need to focus on the other things: social rehabilitation, community living skills, self-care. So that's the reason why the approach needs to be biopsychosocial. It's not just the medication. Just pushing the medication and say, my job is done. Okay, go to the next one. Have you noticed anything significant in this one? So the psychosis also impacts different areas. Okay.
Composite is all of them together.
Sorry?
What's the first one? Composite, all of them together.
All of them together. Yeah. Okay, go to the next one. This is only relevant for people who are giving exam. Okay, but keep in mind that there are a lot of receptors which are also impacted with psychosis. Yeah, don't forget about this. Yeah. This is too much of a high five. Yeah. Is there any question? Do you want me to cover this or just ignore? Olivia? I'm going to give you this slide. You can read on your own. Okay. So you can see with psychosis, it also impacts a lot of functions, cognitive impairment, movement disorders. So when you see a patient, don't try to see in isolation. Try to see in a whole. Okay. So it also impacts a lot of the domains. So that's the reason why when we deal with psychosis, it's not just antipsychotics. We also need to think about other aspect of whether they are able to manage or not. What are the needs? Okay. So when we choose the antipsychotic, we need to be extra careful with the choices of antipsychotics. Keep in mind that with the use of antipsychotic, if you look at the life expectancy, do you think the patient's life expectancy get less with use of antipsychotics?
I think so, because of the metabolic syndrome.
Metabolic syndrome.
Yes.
If you look at some of the papers, it says that it reduces the year by 5 to 10 years less. So that's the reason why when we start antipsychotics, even if the patient are psychotic, but if they are stable enough, not causing any problem, and if they have got a lot of physical health problem, I would not recommend to start medication for them, because my medication might kill the patient faster than the mental health problem. Okay, so it's a balance that you need to weigh out. Okay. So the good thing about the old age is, most of them they reside in the community and care home. So they are well managed. But things are difficult in general population. Why do you think so?
Is it general adult population?
Yeah.
Because most times they are discharged to care for themselves.
Care for them. Yeah.
They might be lost on follow-up and.
Yeah. Loss of follow-up, drugs, alcohol, chaotic lifestyle. Okay. So yeah. Okay. Okay. Can you go back? Do you agree with this one? Low spending, shortage of consultant, lack of policy. Yeah. How can we change this one? Any ideas? Increase training. Go into politics and change the policy. Be AMD, DME, change the policy.
What about low spending? How does that come into play?
The government assigns funding, for NHS. So there are some things which are not in our control, but it's good to be aware. But if you guys are more interested in like leadership and management, this is the area that you can work on. Okay. Yeah. Thanks. So there are some MCQs. What do you think is this one? Which of the following delusion is the GP most likely to find compared to younger adults in late schizophrenic? Any guesses? You have passed your A and B.
Paper A's were long time ago.
You have passed your paper A.
She's just done it.
Yeah. So you should be able to answer.
I would say
Athira?
delusions, but
Plus.
delusions.
This
What's
one?
it hypochondriacal? Is it not
Is
hypochondriacal?
it
Is it
persecutor?
hypo? Yeah, I
I
think
would have said
And compared
hypochondriacal.
to younger.
the psychiatrist delusions.
Oh.
Because most of them will be thinking about like someone is stealing their money. And,
Yeah.
The neighbors,
So-
it's all yeah.
My guess is this too. Okay. D or A. Let's see. What's it? Oh.
Oh.
Yeah. Okay. The hypochondriasis you can see more with depression and anxiety, not with psychosis. Okay. Misidentification, you can see general population. Delusion of religious, also you see between 40 or 60. What do you mean by delusion of reference? Any idea?
So if you see something, you infer a meaning from it.
Yeah. Like, someone in a TV is talking about me. Okay. Yeah. What do you think? Very late onset is characterized by the onset. I think this is in select.
65.
60?
I think
60.
Yeah, let's see.
Yeah.
60.
Yeah.
4 more. Okay. Postural hypertension. We have worked in the ward and we know this.
Respiratory.
Respirable. Let's go.
I don't know.
That's how you feel now.
Oh.
Like on the old age psychiatry.
Oh, it seems like some F1s are not doing their job.
Guys, you need to learn your
Okay.
psychiatry.
I keep saying it.
Yeah.
No, that's seriously.
Which of the following drugs should not be used in renal impairment?
Right now, I think it's a software.
Take a guess. No, I'm just going to ask F1.
Okay.
Because you guys do most of the bloods.
It should not be. I don't know. Human feeling.
My guess is A.
Yeah, it's a software.
Okay, let's go. Yeah. Okay. Which of the following drugs should not be used?
Oh, sorry.
Which of the this is done. 2 more.
Next.
Sensitivity to antipsychotic is linked to which disorder? I think we covered this.
B.
B.
The dementias.
View bodies.
So the last one. Oh, we are done. So, have you guys got any question? You can stop this one.